Welcome back, everyone. As people slowly find their way back to their laptop or computer, video camera. So hopefully you had a good little break. We are starting now with the next session that is dealing with future preparedness for outbreaks, epidemics, and pandemics. My name is Tobias Kurt. I'm professor for public health and epidemiology at the Charité University Medical Center here in Berlin. I'm also professor of epidemiology at the Harvard Chan School of Public Health. I'm very pleased to be the moderator for this next session. And I'm very pleased that we could find three speakers who are giving their insights and expertise to all of us. It's Dr. Michelle Kelly-Irving. She is a researcher at INSERM, the French National Institute for Health and Medical Research. She's located in Toulouse, in France. It's Professor Herwig Ostermann. He is the executive director for the Austrian National Public Health Institute, and Professor Jehovah Sullivan. She's the Chief Bioethics Officer in the Department of Health and lecturer in Healthcare Ethics and Law at the Royal College of Surgeons in Dublin, Ireland. I will introduce each lecturer before they give their little statement, but I would like to give a little bit of the structure that we are dealing with in the next 90 minutes. So we ask each speaker to give in about 10 minutes or so a statement, either with slides or whatever they think they should do to convince you that their points are really important in getting prepared or better prepared for the next pandemics. This is then followed by a discussion. So I encourage you already to note your questions and communicate with us in the chat. We will follow the chat and we'll ask questions. I will be prepared to ask some first questions if you like, but if I see already some questions, this is not about me, this is about you, the audience, to really communicate with us and so that we can all discuss. And I encourage also our speakers to potentially have some questions for the other colleagues. So Dr. Michelle Kelly-Irving will start. So we'll introduce her and she will have some slides ready for us. And then we continue the session with Herwig Ostermann and Jehovah Sullivan. So I'm very, very pleased that Dr. Michelle Kelly-Irving found time in a very busy schedule to be here with us. She's a social epidemiologist who works on the construction of health inequalities over the life course through social to biological processes. She received a doctorate in epidemiology from the University of London and a degree in anthropology from Durham University. She's based at the Center for Epidemiology and Research on Population Health in Toulouse, France, where she is the director of the Equity Research Team. Dr. Kelly-Irving is an excellent scientist and educator and also very active on Twitter. So please follow her on Twitter. She has great insights. Michelle, thank you very much for being here, and I'm looking forward to listen to your thoughts.
Thank you very much. I hope you can hear me okay. I tried to plug in my headset and everything went to a disaster. So I hope this will be okay for you. I will just share my screen if that's okay, because I have a few points that I can illustrate with slides. So if you can just let me know what you can see.
We see the slide set, so if you go into presentation mode.
It's in presentation mode.
That's the presenter mode, so maybe it's better if you...
This one?
Yes, thank you.
Okay, great. So thanks very much. As Tobias said, I'm a social epidemiologist and I specialize in health inequalities research. So thank you very much for the opportunity to exchange with you here today about preparedness for the future regarding outbreaks and pandemics. As many health inequalities researchers and probably many researchers across different disciplines felt when the pandemic occurred, it was a bit like watching an approaching tornado as we saw it integrating into the communities. We more or less knew what was going to happen and couldn't do very much about it. With regards to health inequalities, pretty much the pandemic laid bare what was already known about health inequalities. In terms of socially differentiated exposures, we know already that poverty, adverse childhood experiences, social position, and gender are associated with health outcomes. We know that socially differentiated biological susceptibility is also present because social exposures are biologically embodied. And we also know that there's a social pattern to the access to primary and secondary healthcare. And so we saw all this emerge with the pandemic over time. We saw with regards to exposures that there was a higher incidence of the infection due to people's jobs and their overcrowded living conditions, etc. That in terms of socially differentiated susceptibility, racialized and poorer populations have had higher rates of severe disease and mortality. And we've also seen and still see occurring inequitable access to treatment and vaccines. So I'm going to just touch on two issues that I think emerge as major problems and that I think are actionable to improve for the future. First of all, data infrastructures to monitor health inequalities. And second of all, a real generalized lack of understanding of how some health inequalities are formed over the life course. So to touch on the first point, this was raised by David Nabarro earlier in his video, really to monitor health inequalities and understand what was happening in terms of infection rates and in terms of severity and mortality. Most countries lack good quality data that allow us to do that. We don't have the data on the social aspects in the same place as the data as on the health aspects, and often bringing them together currently is difficult. So we kind of have to piece together puzzles, even though we know what's going on, and set up new studies which take a lot of time and money and investment. There's a lack of data on social aspects collected in healthcare systems, in hospitals, etc. So collecting social data alongside health indicators as standard across the population and within the health system to create a sort of health inequalities dashboard. And down the bottom, there's this screen capture of a dashboard that the Public Health England and the UK have set up. Well, this would be a big step forward. But of course, we have to guarantee ethical data collection, data storage, and use of data. And I think having this would allow us to understand the situations better, to respond faster through targeted research or policies, and make better decisions. But of course, having data and describing it is only the start. You have to go on to the next step to make change. And I'll come to that at the end. The second point that I wanted to make was that we heard a lot over the pandemic when people saw inequalities emerging regarding severity and mortality, people talked about pre-existing conditions a lot. So, but regardless of whether we're talking about diabetes or obesity or something like smoking, all of those things are socially patterned pretty much in the same way and are well known. And this is because health inequalities do not come about just because of the health system in place, but they come about over the life course because people are exposed differently to everyday life exposures. And this occurs over the life course. And we call this biological embodiment of social factors. It's also important to understand this to challenge the genetic essentialism that we kept hearing. Oh, these people are more likely to have severe disease or mortality because of their genetic propensity. But most of the time, this was not the case. And these were really inequalities formed over the life course. So these happen because socially stratified exposures in our everyday lives mean that we are differently exposed to things like pollution, nutrition, but also to physiological stress. And this leads to biological differences and changes that are socially patterned and associated with healthcare outcomes. And this is well known in the literature. There's a couple of examples for you to see here. On the left-hand side with the histograms, we know from data from Porto, cohort in Porto recently, that parental social position that's disadvantaged, so low social class or low education, is associated with global inflammation in children from their teenage years. And if you look on the right-hand side, other biomarkers are also socially patterned with higher disadvantage, socioeconomic disadvantage, being associated with many risk factors. And this emerges relatively early on in life. So just to sort of sum up a little bit, these two problems that I'm putting forwards that could be actionable basically come down to whether there's a political will to do anything about some of these things. To redress health inequalities in emerging diseases or whatever is already in place, there's a political will required to tackle them, partly through primordial prevention policies. So that means universal access to healthcare, paid sick leave, subsidized childcare, housing, etc. And of course, to challenge the economic models that we have that are deleterious to these things in many ways. So the WHO said that the combination of poor strategic choices, an unwillingness to tackle inequalities, and an uncoordinated system created a toxic cocktail which allowed the pandemic to turn into catastrophic human crisis. And I think that these 2 points are things that we can actually maybe do something about. And of course, we have to move on to the political sphere as well. And I'm just going to end by showing you a brief table that I put together to evoke these different potential policies that we could start integrating to tackle health inequalities across primordial, primary, secondary, and tertiary prevention measures. And that might be worth thinking about for the future. But we can discuss this later on. Thank you very much.
Thank you so much, Michelle, for this great presentation and for underlying the importance of social inequalities in this crisis. To the audience, please type your questions that you have in the chat, and please also indicate to whom you would like to address your questions. We will discuss after all three presenters have made their statements or their short presentations. We will continue with Professor Herwig Ostermann, who is the Executive Director of the Austrian Public Health Institute and also an Associate Professor at the Department of Public Health, Health Service Research and Health Technology Assessment at the University of Health Sciences, Medical Informatics and Technology in Halle, Tyrol, the UMIT University. He studied international economics in Innsbruck and Dublin and holds a master and doctorate degree in health sciences from UMIT. Professor Ostermann has an in-depth knowledge of a national and international health system, serving as the advisor of the Austrian Ministry of Health with regard to structural and economic impacts of the health reform. His main research interest encompasses health system analysis and performance assessments, health economic forecasting and impact assessment, health economic evaluation, and health policy implementation. Professor Ostermann, thank you so much for being here with us today, and we're looking forward for your thoughts.
Now it should be fine, shouldn't it? Good afternoon, everybody. I guess you can hear me, and I guess you can also see my slides, which are
all good.
Which is actually the wrong selection of slides. I have to excuse myself, and I have once again to stop the screen sharing. Please excuse me. So many slides to prepare, but this is a speech I'm supposed to give later this week, and it is obviously also in German, which should not be the case either. So just give me 1 second. SMDM online. So I guess this is the right set of slides. So once again, thank you for your patience, and I guess it should work now. Okay, there we go. So now you see the right slides, I guess. Future preparedness for outbreaks, epidemics, and pandemics. Yes, thank you. And thank you for your patience once again. As Tobias already mentioned, I'm the director of the National Public Health Institute, and basically during the past couple of months, rather 15 or 16 months, we served as advisors to the Austrian government. And as such, for my speech and for the 3 points I want to tackle, I took rather the perspective of a health system as a whole, and in particular with regard to the challenges with regard to health systems governance. I will try to tackle 3 points. Just first of all, challenges in the health system governance. I will briefly focus on resilience, and I'm not quite sure whether you have noticed there has been a report on resilience published by the expert group on the European Union level of health systems performance assessment, and this report has been published in 2019 prior to the crisis, and this is always something very important because, you know, your mind changes a bit during a pandemic. However, it's good to take a standpoint back in history, and I think there are some clues that actually very much pinpoint to the challenges we have in the health system. I will then briefly address challenges in decision making, and I will try to highlight or illustrate actually that pandemic management has very much in common with an HTA exercise. And in fact, I believe if you take the principles of HTA seriously, actually it could enhance or support pandemic management to a very large extent. And ultimately, as the title, as we were asked to share our thoughts on future preparedness, I will a bit focus on public health in all policies, and actually the third point will somehow also link to Michelle's thoughts, at least I hope so. This is taken from the report of the European Commission Expert Group on Health Systems Performance Assessment on resilience of healthcare systems. And in fact, the concept of resilience addresses 3 aspects. One is the management system as such and how the health system could react to several crises. Obviously, pandemic was not a crisis mentioned in 2019. And now you see actually how privileged we were in the sense that we did not have to deal with such global pandemics as we have to do now. Resource assessment, the second issue, however, has become quite important during the pandemic. And in particular, it's not only all about workforce and institutional capacity. The third point then addresses the issue of data. And we do have to know the patient flows. We do have to have proper information, not only on the socio-economic dimensions of the pandemic, but also on vital parameters of the health system. A second part of this study was actually a questionnaire, and they asked who should be in charge of dealing with a health system crisis. In particular, obviously, it's the Minister of Health. However, I was a bit surprised that also the Ministers of Finance and others were addressed, also the Ministries of Defense and Interior. And if you take pandemic management, actually also these other policy areas are to some extent involved. It depends a bit on the European Union member state. But you actually see that the whole government now is involved in pandemic management. This is a sketch, actually a very simplified sketch on how the health system in Austria is tied together between the different levels and how financial flows and basically also decision-making processes would take place. And even though we sometimes would argue that the Austrian healthcare system is fragmented, if you take a look at this health system in transition reports of the various member states, you actually see that these sketches almost look the same in any other health system. So basically, we do have these complex systems. And when it comes to govern complex system, actually it's information that counts. And the paradox situation in this respect was described in a publication of 2000 by Buchan, where he actually stated that decentralized health systems, and more or less all health systems, are to some extent decentralized. We do not, there is hardly any central health system. Actually, you have this twofold, to some extent, tendency. On the one hand, actually, you are in need from a central government perspective of an increased data source. On the other hand, along with the decentralization of health systems, actually the decentralized parts become reluctant to share information with you. And at least what we observed for the Austrian health system in early 2020, we changed the operating mode of the health system. On the left-hand side, you see the old way, where very much of health policy and health decision-making was based on bargaining and cooperation between the various levels. And there you see, sorry, it's in German language, basically the new decision-making structure when it comes to pandemic management, which is only focused on the Ministry of Health, and which is organized in a, I would say, paramilitary way, with different essential functions, starting first of all with logistics and ultimately then referring to legal issues and so on. So there was a challenge of rearranging health systems. The second notion I want to share with you are the challenges in decision making. You see here the 3 steps of a blueprint, so to say, of the HTA process, which starts with the initial assessment. I've pinpointed here a picture of the UNETA core model, where you do have the 4 parts of the relative effectiveness assessment, and this is a fairly standardized process, basically. As a second step, there would be the appraisal, which is actually something which has to be geared towards national circumstances. You do have the 5 domains of the UNETA core model, starting with economic considerations, ethical considerations, organizational issues, social aspects, and also legal aspects. And basically, this is now an interdisciplinary exercise, which is very much depending on the context for which this exercise is taken. And ultimately, there would be the decision-making process, which is something fairly political, which should be done by politicians, by the way, and not by scientists. And actually, they have to decide between multiple alternatives. And there is not only one alternative, as we know from pandemic management, but there are many. We do have 2 frontiers, and I feel that actually we as scientists should be well aware of these frontiers. The first frontier was the one we observed in particular in 2020, where we all learned that we do have limited evidence. For instance, on mask wearing, but not only, basically for any measure that was taken as a non-pharmaceutical intervention to counteract the pandemic. And we also learned, at least from the scientific world, that no mechanism or hardly any mechanism for quality assurance was in place. You know, all these pre-printed prints that were shared amongst us. And also we were lacking our usual mechanism of scientific consensus building, for instance, at various conferences. Also, you know, this kind of debate, thesis, anti-thesis, and so on. And to some extent, this was in particular evident in summer 2020, there was a lack of the integration of a broader public health expertise. The initial scientists that were at the forefront of pandemic management were rather virologists and so on, but not public health or not science, not people with a broader public health background. And then the second frontier, which was also somehow mistaken, was the fact that, you know, at this frontier between appraisal and decision-making, scientists sometimes felt themselves as politicians, and scientific advice was sometimes mistaken as decision-making. And there was also, to some extent, a lacking respect for political trade-offs. As a politician, you do have to take into account not only health parameters, but for instance, also the economic aspects and so on. And ultimately, just to give you a brief outlook on how we could, to some extent, also prepare for a future pandemic, there was a policy brief written by Bernd Reichel entitled How to Enhance the Integration of Primary Care and Public Health. And this picture was taken from Levesque et al. From 2014, where they actually show and pinpoint the interaction between public health on the one hand and also primary healthcare. And what I, to some extent, feel, if we want to fight a future pandemic successfully, we cannot only rely on health officials employed at central or local or regional governments, but we have to take into consideration actually primary care, and primary health care, so to say, is the essential and also the basis for public health. And this also involves, as you can see it on the chart, for instance, outbreak assessment, cluster investigation. So we have to bring in all the various levels, and in particular primary healthcare, if we want to successfully control pandemics in the future. Thank you so much.
Thank you very much for this great presentation. And I already noted a few questions here. Please remember to write down your questions in the chat and to whom you would like to address these questions. I was so excited that I said we had 90 minutes. Unfortunately, we only have 75 minutes. So we continue with the last speaker of this session, and that is Professor Jehovah Sullivan. She teaches healthcare ethics and law in the Royal College of Surgeons in Dublin, Ireland. She received her doctorate in medicine from Karolinska and holds a master's in healthcare ethics and in law and human rights law. She's Chief Bioethics Officer at the Ministry of Health in Ireland and provides advice on policy and legislative instruments on bioethics related to issues of health. Professor Sullivan is a member of the National Public Health Emergency Team, which advises the Irish government on COVID-19. She is Vice Chair of the European Group on Ethics, Science and New Technologies, which advises the European Commission, and she's Vice Chair of the Council of Europe Committee on Bioethics. Professor Sullivan, it's a very, very great pleasure to have you here, and I'm looking forward to your thoughts and your talk.
Thank you so much, Tobias. And I won't be using any slides today, so at least the one advantage is I won't get mixed up because I feel Herwig's pain. But I just wanted to thank you for this invitation to participate today in your European Spring event. I'm happy to tell you that it's actually a very rare summer's day here in Dublin. But I think the important thing today is it's been really interesting to hear the insights of the previous speakers. I think that the precise public health, social and economic impact of this pandemic is still evolving. So it's difficult to know exactly the lessons that we need to learn. But I think there are some lessons emerging, and that they are there to help us, inform us, and help us to build future resilience. Pandemics have often been described as sort of like black swan events, and yet we know that scientists and others have been warning of the likelihood of another pandemic for some time, in fact. Epidemics and pandemics are going to become more frequent. We know that. It's probably as a result of our growing urbanized and mobile world population. We're becoming more globalized. And we know that transmission of infectious diseases from animals to humans is going to become more likely as well, because we are having an increasing impact, human societies, that is, on how we're impacting our ecosystems. So all of that's going to become more likely. So in Europe, we have an obligation, in fact, under the international health regulations, but also under an EU directive, the Cross-Border Threats to Health Directive, to actually have plans in place so that we are prepared for these kind of emergencies. Yet it's really interesting that those countries who would have scored particularly highly in respect of their preparedness for these kind of emergencies have not actually tended to be the countries who have done particularly well. So many of those who scored very high, like the UK and the US, etc., are actually some of the countries who've had the highest numbers of infections and deaths relative to their population sizes. So how do we explain that particular anomaly? Well, I would argue it's because we failed to actually see the diversity of the risks brought about by this pandemic. We failed to see beyond lives and public health, and we didn't plan for the impacts that the pandemic would have on economies, on livelihoods, psychosocial well-being, and on civil liberties and human rights. we were too narrow in our preparedness. And I think, you know, we've talked about science and decision making and not to conflate the two. I think there's been a really interesting mantra of follow the science, and that was predominant in very many countries in Europe and beyond. Evidence-informed policy is crucial, and science, technology, and research have really been at the very heart of this pandemic response, as they should be. However, I think it's more complex than that. Science and scientific advice don't emerge from value-free spaces. They can be interpreted, weighed, and applied in very different ways. Values are actually baked into everything, and no decision is taken, no advice is given without values shaping that. And that's whether it's consciously or unconsciously, explicitly or implicitly. Shared values actually give us a basis for our decision making. So I would argue that using ethical principles actually can allow us to guide decision making, and that can enhance trust and solidarity and can strengthen actually the legitimacy and the acceptability of those decisions to our populace. So while ethics can't always provide very precise answers to the questions, the very difficult questions that have been raised in the context of this pandemic, it can really provide us with very useful tools, I think, to help us address the issues, weigh up the competing interests, and reach appropriate decisions. And I think given the enormous and very concrete implications of the public health decision-making that it's had for people during the last 15 months, it requires us, I think, as decision makers and policy makers to be prepared to actually articulate and defend, be completely transparent about the value perspective that we are bringing to bear on the decisions that we're making. So I think the tricky part is then deciding what those values should be. And how can we actually ensure that they represent a collective societal consensus? And that's a very difficult question, in fact. Achieving this in the middle of a pandemic, when decisions are being made by necessity very quickly and without large-scale public consultation, is very difficult and is hardly conducive to a very reflective debate. So I think ideally decisions should be based on values upon which a society has agreed. And this really does underscore for me the importance in the future of a very vibrant and ongoing ethics debate, so that we can engender thoughtful and reflective discourse in the public domain. We also need to go beyond that. We need to have an institutional ecosystem which is inclusive and can answer questions, really fundamental questions about for what, for whom, and, you know, to what good, to what end. Another feature, I think, of this pandemic has been the very welcome emphasis, from my perspective, on the principle of solidarity, which I believe has really been important for societal cohesiveness. This has actually been quite a marked departure from previous pandemics, in which utilitarian concerns, and by that I mean, you know, the emphasis on the greatest good for the greatest number, was really very predominant. But I think solidarity really has come to the fore during this pandemic. And I think it is something we need to build on in order to safeguard resilience for future pandemics. COVID-19 has really, as Michelle has said, thrown into very sharp relief questions about what we owe to each other and what values we want to prioritize as a society. And it's forced us to really examine to what extent public goods are valued in our society. For me, while there are many different theoretical underpinnings for what solidarity actually is, I think it's about standing beside and up for other people in facing a common threat, and basically achieving the shared common goal that we all have of containing this virus. It's a recognition of our shared humanity and interconnectedness, and it's characterized by people actually standing up and acting in mutual support of each other. Solidarity is also being described by the philosopher Jürgen Habermas as the other side of justice. And I think Michelle has very eloquently described that the COVID-19 pandemic has basically exposed as well as exacerbated pre-existing health and social inequalities. And I think that solidarity has to be an important ethical lens through which we should plan for future pandemics. The outbreak of infectious diseases requires a really holistic approach in which we address these links between health crisis, poverty, and structural inequalities. We need to address all the aspects and causes of the crisis, not simply just look at the health issues, but we really need to build in the future and look at our policies in relation to employment, housing, social protection, gender aspects, migration, all of those kind of things to which Michelle referred to earlier. My final observation, if you will, is really relating to the public response to the pandemic and how that was actually influenced by trust, by communication, modes of communication, and by misinformation and disinformation. It's interesting how at various different stages of the pandemic, certain countries were held up as examples of how to do the right thing. It's important, undoubtedly, to be receptive to learnings from other jurisdictions. But we also need to be cognizant, I think, that the public response to what were very onerous public health mitigation measures like lockdowns, etc., they're really influenced by a number of cultural and socio-demographic and political factors. So it's never simple as just replicating what another country has done. The one commonality, though, that you do see is really the level of trust a populace has in its public authorities. And that generally dictates whether people will actually be compliant in terms of the public health measures. So therefore, I think an understanding of the dynamics of trust and how that facilitates or indeed hinders policy responses is really fundamental to effectively planning our response to future health crises. This is not a new finding, the importance of trust, but I do think it has a more profound significance in this era of social media, which has given rise to the accompanying infodemic, as we've called it. I think as WHO has observed, misinformation and disinformation hamper effective public health responses, and they can create confusion and distrust. So we need to think about processes whereby we can make publics preemptively aware of the fact that they're going to hear arguments and discussions and information that isn't necessarily scientifically based. We need to, I suppose, if you want, information inoculation, if you will. And I think that this pandemic has provided us with plenty of rich sources of information to draw on in respect of planning for the kind of issues and misinformation that can arise in the context of this kind of public health emergency. So in addition to all of those things like transparency about the values we're bringing to bear, combating misinformation and disinformation, I think a critical requirement for trust is that the decision makers and indeed the public officials, policy makers have to set an example and lead by that example. We've all seen reports in various different countries of those who we have entrusted with making these really far-reaching decisions about our lives, about our livelihoods, about our fundamental freedoms, and they have failed to actually live up to that. And that can be really devastating in terms of levels of public trust. So I think that we need to be really careful that in the future, that is something that we pay particular attention to. So I'll finish, probably gone over the time, so apologies, but I just want to say that I think it's important to keep in mind that every epidemic or pandemic affects society and different parts and members of society in different ways. So I think for the future, what we need is to have, there can be no single kind of preparedness because every pandemic has its own specific characteristics. What we need, I would suggest, is a toolbox of flexible strategies that can be adjusted and developed in particular epidemiological situations and according to the particular cultural and indeed values that are brought to bear in a particular society. So thank you very much.
Thank you so much, Professor Sullivan, for this great insight and this showing the network and the complexity of the pandemic. So the questions are really popping up in the chat. Beate Jan will help me in looking at these questions. I will start with two questions that are pretty much also some points that I have written down. And I would like to address the first question to Siobhan O'Sullivan and Michelle Kelly-Irvin. So if COVID-19 is a problem, the solution is the people, right? So if that's true, how can we prepare better for future healthcare crisis situations to better understand the people with their diversity, their willingness or ability to compromise, their expectations, their needs, the feasibility to act responsibly, et cetera, so that we really can make implementations on the people that really make a difference and to be better prepared. What are your thoughts about this?
Michelle, do you want to go first?
Okay. Thanks very much, Yvonne and Hurig. Well, I suppose I would go back to the fact that I really reiterating things that I've said and that all three speakers have said, that it's not a question of health on its own. It's a question of making sure that our policies, our systems are better equipped in general towards all forms of crises. We've had a pandemic, but we have the looming climate crisis awaiting us, and that's creating these issues of pandemics. It's also affecting the health and well-being of disadvantaged people disproportionately. So for me, I suppose I'm going to be a bit boring and keep saying that we need to have proper primordial policies in place. If people don't have paid sick leave, well, then they're not going to go and get tested. They're not going to be able to isolate themselves and stay off work because it's a risk to their livelihood. The livelihood and the economic question is not a separate one to health, as David Navarro said, and as Siobhan and Herwig have said as well. These are integral things. If people can't work and feed themselves, that affects their health. And it affects their health for decades, not just for one infection that arises. So it's too short-sighted to just see it as this infection or this issue, but much more broadly as a policy question. So I'm afraid I'm going to probably just keep saying that.
So I would completely agree with Michelle and would simply add, I think that is the kind of the point, the person who asked the question has hit on exactly the point I was trying to make, just the diversity of people. People react in different ways. I mean, who could have planned for that the thing everybody would rush out and buy was toilet paper? So, I mean, and that seemed to have been a worldwide phenomenon. So I think what I would point to the fact that I think we have gaps in our knowledge. We've had some really fabulous science, but we have, I think what we've realized is a gap in terms of behavioral research. And I would point to that is something we need to close that gap next time around, because I think that to, simply transplant what's worked in one country and say, oh, it will work here, simply doesn't work. We saw that. And that at different stages of the pandemic, I'm sure many of you will find this familiar. So during our first wave back in very early 2020, because people were so frightened and it was such novelty and nobody understood what was happening, people were much more willing to take on board the public health advice. By the time we got to January 2021 and our third wave, people were like, hang on, I know how to deal with this. I don't need someone telling me exactly how far I need to stand from somebody else or whether I need to wear a mask in this street or in that shop. So it became a very different dynamic. And I think we have to understand how people's perception of the public health emergency, how their experience of that public health emergency, and because people will experience it differently. Somebody who lives in a very nice house with a very nice garden didn't experience lockdown in the same way as somebody who lives in a one-bedroom flat, maybe in a very deprived area of a particular city. And I think we need to have that research to understand those dynamics for the next time round.
Yeah, thank you very much. I would like to bring it maybe to a practical aspect and ask Herwig Ostermann to give us his insight on some difficulties in making political decisions. There was one time where Austria had really good numbers in terms of transmission rates, but the neighboring countries were still hotspots. And so obviously there was a pressure to then open borders and also probably accepting some risk and potentially also accepting that future lockdowns will happen again. So could you tell us a little bit about the complexity of these decisions and where you have to look around your country and make decisions for your country, understanding that this is a global pandemic with some consequences?
I mean, there are actually many aspects in this question, and the one, I think, general aspect is that we do have neighboring countries in Europe which are fairly small, and all of those neighboring countries do have, on continental Europe at least, to have different regimes when it comes to fighting the pandemic. And we had very weird situations. For instance, this winter, ski slopes were open in the Tyrol, in the northern part, and you could travel across the Brenner border to the southern part of Tyrol, which is part of Italy, where hotels opened up. So basically you could do a proper winter vacation. Ski slopes were closed in southern Tyrol and hotels were closed in the northern part, but it just took 10 minutes of riding with your car. And this shows how all the different policies to some extent are also intertwined, not only on the European level. The rationale for Austria last summer to open up borders fairly quickly was an economic rationale. And the idea was, if we open up our borders, actually our neighboring states are also to some extent urged to open up their borders, and we allow tourism once again, which is quite an economic force in the Austrian policy setting, but also when it comes to the Austrian economy. And this was the idea behind this. And there is, however, some other rationale, which I think we have to discuss right now. And actually, it was Uwe Sievert that put me to this question a couple of weeks ago. And this is the question on how much incidents are we willing to accept, with regard to our society, with regard to our economy. Obviously, last summer, we were not very good in managing stable incidence regimes. And then there was this tendency, maybe you remember, in winter that actually called for a low incidence strategy throughout the whole of Europe. And one of the weirdest, it was not a paper, it was rather a newspaper article I read, I came across at that time, was one that tried to classify a low incidence regime in the political left-right spectrum. I keep it for you, and I don't tell you whether it was left or rightish, but to some extent it was not really a valuable contribution anyway. And but what we have, or what we will come across during the next couple of months with the increasing vaccinations, will be this kind of question, and we have to find answers on that one. And this is a fairly complex answer, and I doubt not only on the level of political decision making, but also at the level of appraisal, whether we can come up with some kind of consensus. All the socioeconomic consequences of non-pharmaceutical interventions would come in, and this discussion on collateral damage, in particular with regard to schooling and so on. I would rather. But maybe Michelle or Siobhan have some thoughts on that one, because I'm still, to some extent, I'm not quite sure on how we as scientists can actually contribute fruitfully to this debate.
Thank you very much, Herwig. while you thinking of adding a few more points, Beate, I missed probably a few questions in the chat. Maybe you can tell us one of those questions.
Yes, sure. And here also kind of a practical one. How do we use value-based reasoning to incentivize the preventative investment needed to address health inequalities? Can you give us some strategies, any particular languages to use or to avoid?
That's a good one. Who would like to start?
I can start. These are really fantastic questions, really. So I think that, so there's two things that I would say there. One is that, you know, we all have this pitching, and Hervik has made reference to it, this idea that happened early on in the pandemic around lives versus livelihoods, the way the two were pitched against each other, which I could never understand. And it took us a long time to try and explain that in terms of as an advisory body, I suppose, to government. That we didn't see it as pitching one against the other, that they were completely intertwined for exactly the reasons Michelle has just said. If people couldn't work or felt that they couldn't, you know, because they, you know, if they had symptoms, they wouldn't be tested, you know, that's fine for me because I get paid my sick leave. For someone else who's in very insecure employment, that's a completely different thing. If we didn't keep people safe, we wouldn't have an economy. There would be no one to work in that economy to generate. But to be blind to either side, I think, is foolish. And I think you have to see them, how they integrate, because they can't be pitched against each other. So I think for me, the really important thing is that it's been interesting, this whole value discussion, right? Because it's always, and maybe I'm being unfair, but it strikes me that a lot of the times the values are the things that are bolted on at the end of the discussion. So we like to use language like solidarity and you know, like, so all the good stuff that we think is important, like equity, like, you know, all of those words. But actually, what do they mean? So for me, I think it's really important as scientists, as decision makers, as policy makers, to actually insist that before we have the discussion about the decision, we actually have the discussion about what are the values we're trying to protect here. So what exactly is it that we are trying to achieve? And what are those values that we want to protect? Because there'll always be trade-offs. That's the reality. So for example, in Ireland, with the National Public Health Emergency Team that I sit on that was advising government, we made very clear that protecting the health service, so ensuring that people could go for non-COVID care, protecting our educational systems, we were really clear about what the priorities were. And we said, and yes, that is going to have impacts for all sorts of other things. But in our view, but at least we were transparent about that. What I would like to see is that would be much more of a societal debate, that we would have settled on that as a society before it ended up being an advisory body who then obviously went to the government to make the decision. So I'll stop there. Thank you.
Is it okay if I jump in? I completely agree with Siobhan. So I think you can start having a deep conversation about values when there's a sort of catastrophe happening around you. It's not the right time. And what we saw, to give you an example from France, obviously everyone knows the French sort of égalité, fraternité. I mean, everyone knows this, right? So égalité, equality, is an underlying concept, a value of France. But the question is it an equality that we're trying to achieve in outcome, or is it equality that we're trying to achieve in the approach, in the way in which public health is implemented? And the French approach tends to be to implement equal policies. So healthcare for all, education for all, etc., which is commendable in many ways, but it doesn't take into account the inequalities of people's lives. So, you know, we need, so these are separate issues. And for example, housing, etc., as Siobhan was pointing out, and Henrik as well, well, we are not equally endowed with our homes, with our gardens, with our, you know, air conditioning, with access to a nice park, etc. So giving people, putting blanket restrictions on people in the same way, not taking those things into account, then in fact exacerbates inequalities and leads to the outcomes being more unequal, despite the fact that the policy itself was an egalitarian one. So there's the issue, of course, of proportionate universalism in terms of the thinking about policies. And that maybe that needs to be, it was a value that I had to bring up in France as, which turned things a little bit on its head and is an issue for some people in France who aren't used to the idea that you would change who has access to what in terms of needs. So yeah, we need to have those conversations before we get to the crunch point.
And to some extent, just one notion maybe to add, and I think it also makes it difficult for us as scientists and also as advisors to develop some clear viewpoint on the pandemic, as we are all affected by the pandemic, not only in our professional lives, but also in our private lives. And I think this makes it so challenging to some extent. And then, you know, to some extent, we do have these ideas on how socioeconomics would influence individual behavior, would influence health, would influence the individual status. But everybody, and this is something very unique for this pandemic, at least I feel, or for this kind of universal crisis, is the fact that it is a universal crisis, and we are all affected in various ways. And as I saw, one comment that actually was that called for effective communication as a subject for all public health courses. I actually doubt that we do have currently a gold standard of successful or effective communication, at least in practice. From history, if you take a look at these essential crises in centuries, actually, this is always a challenge for a government. And in fact, I think that it's a good thing that governments are challenged by the public because the situation is so complex in a way. This does not necessarily mean that another government would do a better job, and I doubt that as well, but the situation as such is challenging, and we need these various levels of discourse and debate. And maybe one answer for a future preparedness could also be to bring in these different levels and try to translate between these different levels of discourse.
Yeah, thank you very much. There are several points I would like to also maybe participate a little bit in discussion. We see now that we need to bring in different domains, different expertises to really see things quickly. And then we are limited by not having the right data or not having data at all, or we cannot access data. So many of the things that you discussed are not new. I mean, we know them since centuries, social inequalities and health, please. I mean, that's something we know since centuries. So now there's a chance here. How can we use this unfortunate crisis to really ensure that if something comes up in the future, or not even next pandemic, because we should use this now to improve health, pandemic or chronic diseases or whatever it is, what is maybe the most important thing for you that you realize now over the last 14, 16 months, that we'd like, if I would have had that, we would have been able to address things a little bit better. Is there such a thing?
I can jump in with the data, because I'm sure you know that this, this is the thing I've been screaming on the rooftops since early on, is especially for France. I know that there are excellent social data in one place and there's excellent health data in another place, and I can't bring them together. So for me, it's simply an infrastructure problem. And of course, I'm not a data scientist or a computer scientist, so I don't know how you make those things interoperable, but I'm pretty sure you can. So I think for me, how can it be that we're still not able to do that? And so even today, a year, 18 months later, I have data requests in for merging that are still not followed through. So I'm kind of begging and scraping together what's really quite crappy data, because I'm using stuff at such an ecological high level that it's just really not telling me anything useful. So there's several things. There's making things interoperable and coming up with a good system that is responsive. There's making sure that that's ethically done, and that we can't count on the fact that whenever a new government comes in or whatever, they won't misuse those things. So that needs to be really part of it. We can't curtail that. And then thirdly, we need to collect the data also in the hospital and the health systems. And today in France, that's not done. We just simply don't know. So for example, if GPs wanted to make sure that people who were in follow-up care for chronic diseases, who are especially likely to not come to the GP surgery when there's a lockdown because they're frightened or whatever it is, and we're going to lose them. And those people are at high risk, especially if they're socially disadvantaged, but the GPs don't know that. They don't have the data to be able to capture who those people are and maybe do some outreach work. So there are just some things which were actually in the health system, it would have helped, I think, to have those data. So, I think that actually these are things we could really do today.
Thank you, Michelle. Do you want to add something?
I was just going to say, undoubtedly, I think that's a common experience, actually. So there's data everywhere, but how do you integrate it and make it meaningful so that we can interpret it in a way that's actually useful? But I also think it is an important point. Many of us, our decisions have been, and we hope have been, data-driven, evidence-driven. But to acknowledge, I think, the lack of evidence, the difficulty of making decisions, and I think Herwig alluded to it before, that you're making decisions quite often in a vacuum where there are a huge number of uncertainties, actually. And I think that, I don't know if you had a similar sort of debate, but here in Ireland, we were doing reviews constantly in terms of the evidence around mask wearing, for example. And that was very difficult because there was no really good high quality evidence. And then at some point we said, yes, everybody has to wear masks. And then everybody went, well, hang on, you were the guys who told us just 2 months ago that you weren't sure about masks. And I think that the difficulty is that it speaks to the earlier point we were making, that even when you have good data sets, and I'm completely with Michelle on that, the need for being able to take all of that data together, I think there is still that interaction with the public around what exactly is the role of science, the certainty that science can bring, and exactly as Herwig said, the difference between science, evidence, and decision making, because that's why I specifically use the term policy informed, not policy based. So I think we need to have a very full and frank discussion with the public around, and we're seeing that come up again now in the context of vaccines and vaccine hesitancy, about what this data actually means. So yes, we need the data. Yes, we need to be able to interpret it, and then we need to be able to explain what it means and where the deficits are and what it doesn't mean.
Yeah, I mean, I think, this issue of mask wearing, actually you can pinpoint the whole pandemic management on the example of mask wearing, and you see all the challenges that came up with. What I am wondering actually is the fact that, in February 2020, we all accepted to get rid of some habits we have developed during our lives. Even take this handshaking, and the last time I shook my hand with somebody, I think, was in March 2020, and we started to wash our hands. Also distancing to some extent came in, but we totally failed with regards to the communication of the need or urgency of mask wearing. And actually now this is going on with regards to testing, and also with regard to the to vaccination. And what somehow got lost, and I'm not quite sure at what particular point we lost it actually, was this somehow this contract between government and the public. And there was this consensus in the first period of pandemic management. And the paradox situation is actually that with tests, also with vaccinations, we can now put pandemic management back to the hands of the citizens. And we totally fail. For the first time, we now have it to some extent, at least in our hands, as a public, also as a enlightened public, so to say, to take solitary action or common action against the pandemic, and we are not able to do it.
Thank you all for these excellent points. And Havik, you mentioned before also the scientific field, I think, has to think a little bit how in a situation like a pandemic, the evaluation is improved. So preprint, you mentioned that. I mean, how much scientific garbage has been published on preprint surveys is unbelievable. And then the health communication jumping on these, etc. So we need to have maybe different systems also to be able to faster evaluate them. But that may be for a next session here. Beate, from the chat, any questions that you have picked up?
Yeah, with respect to trade-offs and valuing and how we as scientists could support, there is one question: can science provide frameworks to quantify values and trade-offs? For example, the willingness to give up as example, 1 month of the freedom to get out of the house to gain B, as an example, so 1 week of life expectancy. So what is your opinion on this?
So if that's okay, Tobias, I think that this is an excellent question, and I think science and scientists can absolutely do that. I think that very often it's useful for people to see. I think the problem has been in the past is that we haven't discussed the trade-offs. And I actually think that as a more grown-up society, that actually what we need to do is to discuss those trade-offs. And I think those have to be systematically presented in some way for people to actually understand what the trade-off involves. I think people will then make different decisions, as I say, based on different underlying values. But if we've already sorted those out as a society, we can say, right, well, we know that this is going to impact this, but we've decided we've made this decision. And then you try and put in mitigating factors or mitigating actions to actually try and minimize the harm on the side that you know. I think it's been really interesting as the pandemic has gone on, and I don't know if Hervik would agree with me, but certainly as somebody who's involved in giving some of that advice, you're constantly trying to strike the balance between minimizing the harm of the actual virus to people's health and well-being and all that, and actually minimize the harm that's being caused by the public health measures that you're actually advocating for to put in place. So I think that's really important. So I absolutely believe that science and scientists can be helpful in a very fact and evidence-based way of presenting that to the public. And then I think the importance of that is it allows the public to be part of that decision-making process. And for me, that's absolutely crucial. It shouldn't be a group of or a set of politics. It is a societal. And just to go back to something that was said, I would agree with Hervik. I think for me, what I hope to see, and I suppose it touches very much on something Michelle said earlier, is I think that after all of this, that what my sincere hope is that while we're all desperate to get back to normal, that in fact we don't lose these lessons and that we actually think about a new social contract and what that involves. Thanks.
Havik, anything to add from your side?
Thank you. I totally agree with Siobhan. I was looking for this social contract, and I think that that's very much the point. I mean, to some extent, just one little notion or one little idea to add. Actually, the politicians should have the legitimation, or they are the legitimate level to decide. So it's not wrong if politicians decide. Actually, I'm happy, or actually I always felt very uncomfortable in a way when scientists were asked to explain a decision in advance that was then afterwards decided upon by politicians. I always felt that this is actually the wrong way. There's also some aspect in there on how scientists should be involved in this advisory process, and actually whether it is advisable or not, or a gold standard or not, to comment upon a decision that was taken where you have been involved as an advisor before. So there are some issues also in this respect, but basically it's about governance and balancing powers, and we are all happy to live in democracies, and power is limited with regards to elections and all of that, but we do need some kind of authority, even though the public has to be involved. It's this interplay between the governance level and the citizens, and we sometimes forgot the perspective of the public, and we were not very successful during the pandemic management to bring them in an active part.
And those were excellent points. And I would like to add that I often have the feeling that it's not understood that a pandemic happens on the population level in the society. And we're not, as scientists, we are not having the right questions that we're trying to study. So the question from the audience was really perfect. And yes, we can do it, but I have the feeling we're not always asking the right questions. And if we don't have the right question, we can do all data collection we want, but we're not helping. We're not helping to solve the problem. So I think we all have to hopefully take this opportunity and take the good things that we see, the problems that we see, and turn this around. And hopefully we can use them in a way that we help to be better prepared for the next pandemic, but also for like chronic diseases. And it's not just about pandemic. Okay, we're running out of time, so I don't want to go over because the next meeting is starting soon, and I would like to give every one of you, the audience and the speakers, a chance to stretch and to get some water or tea. So thank you. Thank you very, very much. This was an exciting session. Thank you for your insights, for your expertise, for your work during this pandemic, for your motivation also, because I think you're highly motivating people like me, hopefully also the audience, to continue working in this field, and for laying out all the important aspects of the pandemic, what you have learned and what you think should be changed so we are better prepared. So thank you again. It's been a great pleasure. And I hand it over to maybe Silke, who will announce the next session and what we're going to do after the break.
Yeah, so we will have a 15-minute break now. And after that, we start our session on risk communication.